About 1 in every 5 U.S. adults has doctor-diagnosed arthritis, the most common of which is osteoarthritis, a pain, aching, or swelling of the joints and back. Some treatment options may include physical therapy, medication, or surgery. Stay tuned to learn more about how Catholic Health Services of Long Island can help you to return to the life you remember before the pain and guide you with confidence through the process. It's on today's episode of CHS Presents Lifestyles at the Heart of Health. Hello, everyone, and thanks so much for joining us. I'm Jane Hansen. Joint replacement or back surgery can seem overwhelming to a patient. To help you navigate the pre- and post-surgical instructions, you can be sure that the team at CHS will be there for you every step of the way. And joining me now is Francis Lozado, the Director of Orthopedic Navigation from Catholic Health Services, to tell us all about the care navigation we can expect. Welcome. It's so good to have you here.
Thank you.
So talk to me about what is an orthopedic navigator?
The orthopedic navigator's role is to provide the highest quality of care for each patient undergoing a joint replacement surgery. We kind of follow the patients throughout the entire surgical process, from pre-surgical education to 90 days after they're discharged from the hospital. We pretty much end up being the liaison between the patient and their orthopedic surgeon, their primary care physician, our Catholic home care agency, and even the outpatient facilities that, the outpatient physical therapy facilities that they would go to after their hospital stay.
Boy, that must be a relief to them. I mean, I wonder what they say to you when you show up and you're helping get them through all this, because it's a lot going on.
It is. We do have the opportunity to meet the patients in the hospital, so they know who we are. They know who it is that's going to be following them and calling them at home to ensure that everything is okay, that they're getting back to their activities of daily living. We call them weekly after they're discharged from the hospital to ensure that they're getting to all their appointments safely. Also to find out, ensuring that they're participating in their rehab and everything is going as planned.
So is this called the CJR program? Is that what it is?
Yes, CJR stands for Comprehensive Joint Replacement. It's a Medicare program that measures that tracks the quality measures and the total cost of care.
Right. So
for
it's
the patient over a 90-day period.
It's about being efficient. It's also about being effective and making sure that everything seems to work really nicely.
Correct.
Sure. What's the biggest problem that people who have either a hip or a knee replacement, what's the hardest thing for them as they're coming out of it?
I think it's their fear of going back home and thinking that they're not going to be able to go to the bathroom, or they won't be able to get dressed or get a cup of water from the glass of water from the refrigerator. So it's helping alleviate the fear, encouraging them and reinforcing that they will have home care there to educate them. The nurse comes in, the physical therapist, as well as we also educate the caregivers as well that will be there at home with them to help alleviate the stress on them as well.
Sounds like you have a lot of members of your team.
We do. We have 5 orthopedic navigators throughout the Catholic health system. It's a multidisciplinary team. We have registered nurses, physical and occupational therapists. So the multidisciplinary team kind of helps us with not only addressing the patient's rehabilitative needs, but also their medical needs as well.
Sure. And what about, they have this big fear, but do they have more pain with the knees or with the hips?
Patients do tend to have more pain with the knees as they do with the hips. It's just a little bit more of a complex joint. but that's all addressed in our education classes that they go to prior to surgery, and they're educated on a lot of the exercises they could do prior to surgery, how to prepare their home before surgery, and what to expect.
What's an idea about how you have to prepare your home? What kind of things do you have to do?
Fall prevention is reinforced a lot, making sure that you're removing any scattered rugs that will be in the way when you come home using a walker, making sure you have chairs at home that have armrests that are high enough for you to get up and not sitting too low. Your fluffy, comfortable couches might have to be avoided for some time.
Because you sink too far into them?
Yes, and then you'll have a hard time standing up.
Oh, there's so much to think about that on an ordinary basis. We wouldn't even realize that our home can have some hazardous elements to them for that brief period of time.
And your bathroom as well, making sure you have the equipment
so
when you come home.
You talked about the team, so I want to know what kind of are the roles at home care and the skilled nursing facilities? What do they play in all of this?
Well, our Catholic home care team is pretty much the backbone of our patients' experience. They're led by Mary Ellen Pollitt and Gail Silver. They pretty much ensure that our patients are receiving the right care, right and appropriate care at home, and keeping them safe at home and preventing them from returning back to the hospital. For the skilled nursing facilities, not too many patients are really going into, there's really not a need for patients to go into skilled nursing facilities. We've had with our surgical procedures, they're a lot more advanced, so there's less need for patients to go to skilled nursing facilities. However, we do have patients that are at risk, so the patients that do need to go to a skilled nursing facility, we have paired up with a couple of our own skilled nursing facilities in our own system, which is Our Lady of Constellation, Good Samaritan Nursing Home, St. Catherine of Siena Nursing Home, to ensure that the patients are getting the quality and efficient care that they need at home.
Yeah, well, obviously that's pretty important. What is it that you like about your job, about what you do with people?
Actually being responsible for the patient's satisfaction and making sure that they did have a good outcome after the surgery plays a key role. We also, plus the relationships that we build along the way, we work closely with our care managers in the hospital, as well as our own Catholic home care team, and educating the families at home to make sure that everything's going to be okay.
Yeah, and I guess that's the reassurance part. That's got to play a really big role in what you do.
It does, and that's what we do when we make our follow-up phone calls at home. We make sure that the patient is okay, they're comfortable, that they're walking, they're following their exercise program. Any questions that family members may have, they have our number. They call us if there's any questions or issues that arrive.
One of the things that I keep hearing from people that I know who have some kind of arthritis in their knees or have hip issues, etc., is they're always afraid to have the surgery, and then afterwards they say, I wish I would have done it sooner. Do you hear that sort of thing a lot?
I hear that pretty much all the time. Yeah, it's the fear. They don't know what to expect, which we've had great success with our pre-education classes at the hospital, that they do, a lot of their questions get answered.
And especially now with new technology and new modern kind of therapies and ways of doing surgery, it's so much more advanced that the surgery itself doesn't take as long. They're up quicker.
Yes. Many of the patients are up the same day that they have their surgery. And based on a lot of the follow-up phone calls that we've had with the patients, in a couple of weeks they're back to driving, they're back to gardening, even just going to the supermarket. Activities that they loved doing but couldn't do because of the pain that they were having. So that's pretty rewarding in itself.
Yeah, the pain relief too must just be the ultimate.
Yes, the waking up in the morning and being able to take that first step without pain.
What tips do you have for people who might be watching right now about things they might be able to do to either avoid getting, or to prevent maybe the arthritis from getting? I don't know if you can do anything about that, but also to, to take care of themselves so that maybe they won't have to get to the surgery part.
I would say just staying active, just not sitting around on the couch. Also diet, plays a big part of it.
That darn diet always
Yeah.
plays a role, doesn't it?
It does. But walking
Yeah.
is probably the best thing that, you can do before surgery, after surgery, as preventative.
Well, I have a brother who has had both of his hips replaced, and I'm telling you, he got up walking, and he said it's the best thing he's ever done. He
I
wish he
can
would have done it a
imagine.
lot sooner. So good work, and keep it up, and I'm sure people totally appreciate what you do. And I've learned something new about an orthopedic navigator.
Yes.
So stick around. We're going to take a quick break, but don't go anywhere. We'll be right back after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. The Joint Endeavor program at Mercy Medical Center is designed to achieve the best results possible through a team collaboration that addresses the entire continuum of care. Joining me now is Bernadette Roach, the hospital's Joint Endeavor Coordinator. Welcome.
Thank you.
What is a Joint Endeavor Coordinator?
The Joint Endeavor Coordinator is somewhat of a navigator helping patients through the whole continuum of care. So this program came about 20 years ago. And it's a concept. It's a team approach to taking care of a total joint replacement patient. So it's not just the surgeon and the nurses and me who are involved with the patient's care, but we bring anybody who comes in contact with a patient during their hospital stay is involved in our team. So pharmacy, dietary, physical therapy, occupational therapy. We're all a team. I coordinate, so try to bring everything together to make the patient's stay in the hospital go smoothly.
So you bring a member of what?
We bring a member from each area to a monthly meeting, and we talk about any issues that may have come up with our total joint replacement patients. How did we deal with it? What can we do to improve it next time? So Mercy's been 5-star rated all these years because of a lot of great things that have come out of our program.
But it's changed a lot, right? Because when you
Yes.
first started working with patients,
30 years ago, 30 plus.
What was going on then?
Back then, was fewer patients because the patients were more elderly. Now we see joint replacements all the time because the baby boomers are living longer and remaining active. So back then it was more elderly patients. We didn't manage pain well back then. We didn't know how to avoid complications as well as we do now. So my patients were with me for 3 weeks back then.
They'd be in the hospital for 3 weeks?
In the hospital for 3 weeks.
And now?
They even came into the hospital several days before surgery to have their pre-testing done, their medical
Wow.
clearance. So a lot has changed over the years.
Replacing a hip back then was a very big deal.
Very big.
So,
yes.
and today?
And today, some of the patients go home the same day of surgery or the day after.
You've brought with you, this is a hip bone.
It is.
And
So that's the femur. It's the biggest bone in the body. And when the surgeon does go in to do the surgery, there's several approaches. They can go in from the front or the more posterior in the back a little bit. What they want to do is actually replace the head of this femur had cartilage on it, which is now eroded. All right, and not only did it erode, it didn't erode smoothly. So there's a lot of bumps and cracks and fissures and things like that. So it's very uncomfortable for the patient. So the surgeon wants to fit a prosthetic piece inside the patient, like that will go inside the bone like this.
that goes
It
in?
looks scary, I know.
That is so big.
And on top of that, they will
Gross.
they'll put a new head to this femur bone. Okay, and then
That goes on?
this does
There's
too.
a lot of parts.
So there's a cup part to your hip, and typically the hip is a ball and socket, and it would have nicely went smoothly through here. So this is, once they clean out that cup area, this is the piece they want to put on here.
Okay, so somebody's going to get this done. Beforehand, you tell them what do they need to do, and
Yes.
then afterwards, I mean, it's amazing to me that you get people up walking within hours of the surgery.
We do. over the years, we've learned how to manage pain much better than we used to. So we can actually inject pain medication right into the tissue around the joint if necessary. And we've also learned how to manage blood loss. That used to cause a lot of complications over the years with my patients because their blood pressure would drop. Patients would get lightheaded, dizzy. So they couldn't participate in therapy like they did. Sometimes they'd even need blood transfusions. But now with a simple medication they can give in the operating room, most of my patients don't lose a significant amount of blood. All right? So we can get them up the same day, get them moving. Some patients go home the following day. Most of them do, actually.
So before the surgery, what is it that you tell them? I know you have them come to a class where they learn all kinds of things. What do you tell them beforehand that they need to do?
Well, first, simple stuff. Basically, stop your meal, arrange for some help at home, all right? Because you're not going to be completely independent, but, have some friends or family stop in and make sure that everything's going okay. Stop the newspaper, get some dental work done. Maybe you have an infection that you're not aware of, so we want to make sure that you're at your healthiest. And then they're also going to, then we progress to pre-surgical testing and their medical clearance before surgery, and then we bring them into a class. We bring many members of our team in to speak during that class. A big focus during the class is preventing infections. A lot of people don't realize that we all walk around with bacteria on our skin. Doesn't typically make us sick, but you put your fingers in your mouth, you're not going to get sick. But once your resistance is a little lower after surgery, many things could let bacteria into your bloodstream.
Did you tell me that even a mosquito bite could cancel surgery?
It could, because any opening in the skin is a potential port of entry for a bacteria.
And this is some special kind of...
It is. So one of the things I teach them in the class is to keep your skin at its healthiest. First of all, make sure you have no cuts, scratches, or mosquito bites. But we also want to have the patient wash from the neck down, pay special attention to that hip or that knee, and they're going to do this for 3 days before surgery.
Boy,
and
that's
it's
extensive.
antibacterial. It helps get rid of infections.
Okay, and then we talked about the pain management, which is a really big deal. So I know that this has to do with knees, correct?
Historically, knees have always been more painful than hips.
Okay,
Right? The hips are only holding up half your body, the knees 3/4.
Yeah.
And there's just more nerve endings in the knee.
So what is this?
So there's several nerves that send the signals to your brain that you're feeling pain. And somebody along the line came up with the idea, well, why can't we just numb up the knee like a dentist does with a Novocaine? So what this is in the cane family, but happens to be Marcaine. This is called an on-cue, all right? But it's also known as a femoral nerve or sciatic nerve catheter. And an anesthesiologist will thread a catheter along this nerve that sends the signals to your brain. And externally, we attach this. So outside the body, this is what you would see. And this ball of medicine just gets smaller and smaller over 3 days as it releases the medicine. And it can numb the patient, the whole area. And it can work up to 3 days. Some surgeons prefer to use this. Some will just inject the tissue with the same similar medication.
Right, but again, it's all about the pain.
It's all about pain management.
And I know that you have something pretty unique at Mercy, that you've got this little ice chest over here.
So this is unique at Mercy, although
Let's bring it up.
most facilities will also use some form of ice therapy. Ice therapy, most of the surgeons believe very strongly in because it helps reduce swelling and thus will also help reduce pain in the knee. So this machine we actually give to the patients because insurance won't cover it, okay? And it's theirs to keep because it's not reusable. So what we do is we fill it up with ice, fill it up with water, attach it to this pad that goes on the knee, and plug it in, and it circulates ice cold fluid through here.
Boy, I want one of those for lots of places.
It's theirs to keep, and they can take it with them to a rehab or home or wherever they go after surgery.
So all of this is to help prevent complications,
Correct.
to have pain management, to make the outcome even better
Yes.
than one would hope.
Yes,
We've come a long ways, wouldn't you agree?
we have.
So what's the most important thing for anybody out there that's contemplating some kind of hip or knee replacement surgery? What should they know?
They should know that although it sounds scary, they're going to be so happy they did this, which is what all of my patients tell me. I wish I hadn't put this off for so long. We're going to get you there. We're going to help you, guide you through this, okay? I feel that because I see the patients beforehand and then I see them in the hospital, I call them when they get home. I kind of provide a concierge service for them.
That's a good description.
So, you know, it's somebody there, a familiar face, feel much more comfortable. They can reach out to me at any time. I'm a liaison with their surgeon. So it's a nice service we provide. They're not alone. They come to the class and they realize there's 10 other people here having the same procedure I'm having. So the doctors do this all the time. They're in good hands.
It's endearing and it builds trust.
Yes, it does.
Okay, stay right here because we're going to take a quick break, but our discussion will continue right after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. As we wrap up our show today, some final thoughts with our guests, Frances Lozado and Bernadette Roach. Now, you were just telling me, Bernadette, that actually one thing people can do way in advance is to strengthen themselves by doing some prehab?
Yes, the CHS system has a prehab program. It's a complimentary 30-minute physical therapy evaluation, and it's offered in all of our outpatient facilities. So most of our hospitals have an outpatient physical therapy department, and you just make an appointment. They'll do a physical therapy evaluation. They're going to ask the patient what their home is set up like. Do you have a lot of stairs? Do you have a high bathtub that you have to climb into? Things like that. So they'll guide them and give them advice how to manage afterwards. They're going to recommend strengthening exercises, what they could do to help strengthen the muscles around the joints before surgery so it will all go smoother for them.
And how important is that?
Oh, it's very important because the stronger your muscles are, the more support you're going to have after your surgery. So,
and one of the things that you were talking about, Frances, is that the most important component of all of this, of all the teams, is the patient themselves.
Yes. We want the patient to be proactive in their recovery phase, doing the exercise that they were taught by their physical therapist, and walking, staying active in the home, getting outside, whether it's using their walker or their cane, but get that joint moving.
Because if they don't get that joint moving, what happens?
They're going to end up back at back at mercy.
And then you have to have some, what do you do at that point? Then there's
well,
scar
if the
tissue?
patient ends up not getting the full range of motion that we hoped, for example, in their knee, scar tissue can develop. And then they would have to come back and go under anesthesia to have the scar tissue broken up. So it's not painful because they're under anesthesia, but the whole idea of starting rehabbing it all over again is not desirable. So this is another thing that I go over in class, and I explain to them, let's get it right the first time. And then you don't have to come back for something like that, which happens rarely.
But if you think about it logically, we talked a lot about pain management. And if you haven't managed the pain, it would be, sometimes it's really hard to do the rehab because it hurts too much.
Yes.
So what do you do in that case if somebody says, I can't do this, it's too painful?
Well, we even have anesthesiologists who can come up and see the patient, or pain management specialists, because everybody's pain is different. Your pain isn't the same as mine or yours. So we have to treat every patient individually, and what works for you might not work for you. So we have this, fortunately in this day and age, there's plenty of medications out there that we can use. And if we can't find the right recipe for a patient of what works, then we can contact an anesthesiologist or a pain management specialist. So like I say, in this day and age, it's very unusual to see a patient writhing in pain. I remember those days, but I don't see that anymore. So it rarely happens where the pain is unmanageable.
How often do you actually see any kind of an infection? Because I think one of the things you were stressing before also
I'm very proud of the fact that in my facility that it's so rare that I see any of the complications. I don't see infections. I don't see blood clots. Patients with pneumonia. I saw them over the years, and we don't see that anymore. So it's very nice to be able to say that.
But you have to give them some kind of guidance about preventing infection, don't you? beyond.
Yes.
I mean, we talked about the scrubbing ahead of time.
Yes, but even afterwards, we tell patients that once they get home, they should be getting into freshly laundered clothing every day. They should be changing their sheets. I don't want the dog up on the bed with you, okay? Things like that.
But the dog loves you and wants to snuggle.
But there's a chance that more bacteria will be in your
Right.
surrounding. We tell them we don't want them submerging right away. So in other words, no tubs, no hot tubs, no swimming until the surgeon says it's okay. Because if there's bacteria sitting in that tub, it could conceivably get into that, seep into that joint, and we don't want to take that chance.
But I mean, into where it's been sewn up and all of that. Is that what you're saying?
Right, until it's healed completely. We would just want to make sure that no bacteria gets in.
There's so much to think about. It gets very complicated, doesn't it, Frances?
It does, and everything that Bernadette just said is what the navigators reinforce when they call the patients at home. You know, are you seeing any symptoms of redness or any oozing at the incision? And then we just remind them of the safety tips with the pets, even just being careful walking with your walker or the cane, that the dog or the cat doesn't walk between your legs, because that has happened.
I would imagine that there are a lot of people, you talked about baby boomers and being active for so much longer, and that's, we've kind of seen a lot more cases of joint replacement. They're not people who like to sit around. So it's probably a little hard to get them to even sit down long enough to focus on.
It is, and I find that in the hospital, that's probably one of the most frustrating things for a patient, is to be dependent on people at first. Fortunately, we're getting them moving quicker, so they are less dependent, but I tell them, please don't try to get up by yourself. If I thought you were ready, we would have discharged you already. So over the years, I used to see patients fall every now and then.
Oof.
And, you know, sometimes they're on a blood thinner to prevent a blood clot after surgery. So I don't want them falling and start bleeding. Could be, you know, a disaster. Now, I don't see that so much because, like I said, patients aren't as unstable. They're in less pain, so they're moving more quickly. Their blood pressure isn't low, so they're not getting lightheaded because they haven't lost too much blood in surgery. So thankfully, I'm not seeing patients fall like I used to.
Any final thoughts on what you want people out there to know about the joint replacements and how to deal with them effectively?
Just that you're going to need the surgery, so the better educated you are prior to the surgery, and the more prepared you are, and as well as your family, the better the recovery is going to be.
There's so much help. I can't believe what's offered by you guys. It's really amazing. You, final thoughts?
Just to reiterate what Frances is saying, you know, studies have shown that patients who come to the class and have the education do so much better because they know what to expect of themselves and the caregivers. There's no surprises.
No surprises, bottom line. Thank you guys for everything that you do. I really appreciate it, and it's been really fun to hear your stories and how you help people. So keep it up.
Thank you.
Thanks to both of you, and as always to you for watching. For more information or to schedule an appointment with Catholic Health Services, simply call 1-855-CHS-4500 or visit chsli.org. Thank you for joining us today. I'm Jane Hanson, wishing you goodbye and good health.